Welcome to the Fortrea podcast, where we explore the science, strategy, and stories shaping the future of clinical research. I'm Dr. Mala Puri, Senior Medical Director at Fortrea, and today is the second in a special two-part series with Breakthrough T1D. In this episode, we're focusing on a pivotal moment in type 1 diabetes pediatric care, the critical first 100 days following a pediatric type 1 diagnosis. Joining me today is Dr. Sanjoy, Dutta, Chief Scientific Officer at Breakthrough T1D. Together, we'll unpack the paradigm shift in how we understand and treat type 1 diabetes, from a metabolic condition to an autoimmune disease, and what that means for trial design, patient care, and family support. We'll also explore the real-world challenges families face, the evolving role of advocacy groups, and how collaboration across the ecosystem is essential to improving outcomes for children. Let's get started. Thank you, Sanjoy, for joining us today.
It's my pleasure.
So I thought we could start by talking about what is driving the paradigm shift for treating type 1 diabetes as from a metabolic condition to more recognizing it as an autoimmune disease. And why does this matter?
Thank you, Mala. That's a very central question in this field here. I would posit we need both. We do need to continue treating the metabolic component of type 1 diabetes because the clinical manifestation of type 1 diabetes is dysglycemia. So you need to be able to control that for day-to-day glucose control and avoiding long-term complications. However, with our deeper understanding of type 1 diabetes as an autoimmune disease, particularly in the last 30 years, we know that glucose management is a band-aid. It's palliative care. You're treating the it's a symptomatology that you're treating, you're not treating the core of the disease. So it is very critical, Breakthrough T1D and many others in the field, it's almost a movement right now to be able to establish type 1 diabetes as an autoimmune disease and treat the central autoimmune component to it to truly modify the course of the disease, because that's the only way we'll be able to slow down, stop, or reverse the disease, i.e. cure the disease. So this is we're in a critical moment, and I'll speak more about therapies that we are pursuing in this field here.
No, that's very interesting, and I agree with you. The focus in the past had always been on treatment of the glucose and looking at the hemoglobin A1Cs, but now it seems like hemoglobin A1C itself isn't necessarily the optimal endpoint in the trials and in targeting that. And can you speak a little bit more about what other endpoints we could be considering for some of these trials?
Yeah. So another great question. Type 1 diabetes has two essential components that we are trying to tackle. The autoimmunity, of course, the self-destruction of insulin-producing beta cells. And the other is the frank loss of beta cells. So in order to tackle the disease and see if a therapy is working, if you're making any improvement in the person with T1D, you have to get a read on either the autoimmune component of it or the beta cell insulin production, or ideally both. Neither of these are addressed by hemoglobin A1C. Hemoglobin A1C, as you know well, and many others do, is an excellent marker, but only for long-term complications, which is the 90-day average glucose. That does not tell you day-to-day glycemic variability. That does not tell you about hypoglycemia. That does not tell you about extreme hyperglycemia. It tells you nothing about beta cell function and certainly nothing at all about the autoimmunity. Therefore, hemoglobin A1C in the first 100 days is not the ideal marker to be able to get a readout if you're making any improvement in the person with type 1 diabetes.
So I'm glad you brought that up. Why are that first 100 days after a child is diagnosed with type 1 so critical? And, what's changing in how we approach these studies within the first 100 days?
Yeah, absolutely. And Mala, one can debate, is it 100 days? Is it 28 days? I mean, one month, or is it 1 year? And that speaks to two different things. One is the rate of progression of type 1 diabetes is generally known to be faster or more aggressive in pediatric and adolescent population than in adult onset type 1 diabetes, which we're not going to discuss today. So in some cases, it might progress as fast as 28 days to a month-ish. In some cases, it might be 3 months. In some cases, 100 days. But the criticality here comes up in that those 100 days are critical, or whatever the number of days are, because you still have insulin production, beta cell. And we can speak about staging in a second, but type 1 diabetes is a progressive loss or destruction of the insulin producing beta cells. When you lose a critical mass of beta cells or insulin production, you need exogenous insulin to be supplemented for your or metabolic control, glucose control. So when you're put on insulin, when your hemoglobin A1C exceeds a certain number, which we all know, you still have remaining beta cells. So in some people, it might be as much as 30%, 40%, and some people it might be less than that. Those beta cells are very critical to preserve. And any therapy that preserves the beta cell not only provides you immediate or acute benefits, such as hypoglycemia reduction, better glycemic control, less glucose variability, but I call it money in the bank. In the long term, it has been shown that any amount of residual beta cell function you have protects you from long-term complications. We don't fully understand the mechanisms of it, but it's sufficient to say that your own beta cells are the best beta cells you'll ever have.
That makes sense. And I think this is why this is often referred to as the honeymoon phase for a lot of these patients. Now a lot of these kids are being put on these closed loop systems, and they can be given almost immediately. Does this create any challenges or open up any opportunities for these families?
Good question here, both. So we are very thankful. We did a lot of work, Breakthrough T1D, GDRF at the time, in what we call artificial pancreas systems or automated insulin delivery systems. And then many other funders, device companies also came in. And now we have excellent glucose management devices, continuous glucose monitoring systems, very sophisticated pumps or smart pumps, if you will, and now combined systems called AIDs, as we just discussed here. So it is an asset. It's providing better glucose control benefits, peace of mind, reduced burden. And remember, it's not just the person with type 1 diabetes, it is the ecosystem around the person, the caregivers and the school the child is going to, so on and so forth. So it's been an asset. At the same time, does it pose challenges? Yes, but everything is surmountable. What happens is people are having improved glucose control system, thankfully, for these devices. And so enrolling in clinical trials sometimes becomes difficult, and to demonstrate a benefit of an immune therapy or a beta cell protection therapy becomes a challenge because you're getting very good glucose control now. But those challenges are fully surmountable here in terms of how do you show that benefit once we graduate to using other markers that we just discussed on the previous call. Not hemoglobin A1C, but other sophisticated markers. Then when we graduate to those using those markers as provable endpoints, then it becomes easier to assess the benefit of a therapy.
That makes a lot of sense. One of the things you mentioned before is, type 1 diabetes is really a continuum. We have the different stages. And can you walk us through how the new therapies are targeting the different stages of diabetes along this continuum? And also to that point, like, how are we identifying and diagnosing these children earlier and earlier?
Yeah, I will address both together. So I in 2015 or 16, about 9 or 10 years ago, we published, along with many thought leaders in the field, the first understanding of the stages of type 1 diabetes. I would posit it's been a seminal for us for many reasons. A, understanding the disease, how it progresses. B, identifying therapies, to your second question, identifying therapies for each stage. And C, identify these individuals. Staging essentially right now, in our best understanding today, and that might evolve, it is evolving actually, is there are 4 stages here, in which there's progressive autoimmunity and increased autoimmunity, so to speak, and reduced beta cell number and function. So stage 1 is where you have frank autoimmunity, but you still have sufficient number of beta cells to manage your glucose levels, so you will not be able to, it's asymptomatic. You don't detect any glucose changes when you do a finger prick, or you wear a CGM. Then when you move to stage 2, you still have the frank autoimmunity measured by autoantibodies in the blood that I'll get into in a second, but now you've lost sufficient number of beta cells that your ambient glucose is in control, but you're not able to handle what we call disturbances such as a meal. And so you're not able to handle a meal because now you've lost some amount of beta cells there that's not doing the first phase insulin secretion, which is so critical in a person without diabetes, is the immediate release of insulin when there's a burst of food or glucose in the body. That's stage 2. Stage 3, which we didn't mention, but we just discussed earlier to an earlier question, Mala, is when you've lost even further beta cells, further insulin production, and now you're frankly insulin dependent. You need exogenous insulin. Stage 4 is a loose term. Stage 4 is a loose term. And I don't mean loose scientifically. I mean loose because it's a broad spectrum. It's basically all the people living with frank type 1 diabetes is insulin dependent, and some have good glucose control, some have not so glucose control, some have complications, some don't have complications. So stage 4 is, I'm saying it's loosely a broad group of people, but scientifically we have an understanding of that. Then your second and as part of the question was, how do you diagnose these people? It's exactly what I mentioned about autoimmunity. So there are markers that has gone, a lot of research has established there are autoantibodies. These are antibodies to the beta cell that the autoimmune system has created in the body for mechanisms we're still trying to understand, is that you can measure these antibodies. Primarily, it's 4 autoantibodies that we try to measure here. And when you have 2 or more of these autoantibodies, you're considered to be in stage 1, but you still have normal glycemia or normal glucose control. So right now, the way we screen pediatric and also adult populations of T1D is screening for autoantibodies. And once you have 2 or more autoantibodies, there are other factors that we won't be discussing today. Family history, genetics plays a huge component here, so many other environmental triggers. There are various other factors that play into it, so it's a composite. But the bona fide markers are the autoantibodies. 2 or more is stage 1, 2 or more plus dysglycemia is stage 2, 2 or more frank dysglycemia is stage 3. So that's how we currently understand.
Are all children being tested for these autoantibodies, or is it only children that have like a family history or a high risk of autoimmune disease?
$1 million question. Ideally, we should have all children and adults, frankly, tested for autoantibodies. The reason is, and I'll indulge you a little bit, the reason is because there's a huge genetic component in type 1 diabetes. And if you have a first-degree relative or an immediate family member, parent, sibling, child with type 1 diabetes, your risk of getting the disease is 15-fold higher, as we understand from a lot of research. However, 90%, 90, not 19, 90% of the people newly diagnosed with type 1 diabetes do not have a first-degree relative with type 1. So there's a dichotomy here. So yes, families should be screened because they are at a heightened risk of another member getting type 1 diabetes. But you're going to miss out 85 to 90% of the people that are also at risk of type 1 diabetes. So historically, we've had only familial screening as the mainstay. But for about 10 years or so, Breakthrough T1D, JDF at the time, and others around the world started screening what we call the general population screening. So go beyond the family members. And we are trying to work very hard, not only in establishing facile screening pathways, inexpensive, less invasive, easy to implement, and reimbursed. So we are trying to implement general population screening in the United States and around the world right now. And that's a major focus for Breakthrough T1D because we need to find these people. We need to enroll them in clinical trials. We need to treat them with approved therapies. And most importantly, which we didn't discuss yet, Mala, avoid diabetic ketoacidosis at diagnosis, which screening for autoantibodies and monitoring them has shown we can reduce them from upward of 50, 60, 70% DKA rates to below 5%. It's huge. And this DKA, as you, as a clinician know very well, it has both acute and long-term disadvantages or health effects there, and which we won't get into now, but there's many benefits of screening and monitoring. Screening alone will not avoid DKA. You have to monitor these individuals.
And, is there any sort of frequency with which they need to be screened? Because as we know, the antibodies can develop, right?
Excellent question here. Our current understanding, which I will say is pretty sophisticated, in the pediatric population, we are currently, our data suggests, it's all data driven, the optimal screening ages are 2, 6, and 10. That's when autoimmunity flares. That's when, you seroconversion happens in your blood here. So right now, 2, 6, and 10. Now, depending on some populations, depending on feasibility, people are using ranges like 2 to 4-year-old, and then 5 to 7-year-old, and then 10 to 12-year-old, because you have to look at the convenience and the heterogeneity of the disease here. But largely speaking, below the age of 12, we're suggesting screening. This screening frequency, which you didn't exactly ask, but I will mention, will also change to become more frequent from the strict 2, 6, and 10-year age once you show one autoantibody. Because when you show one autoantibody, then you should be screened annually, because what happens is your likelihood of developing the second autoantibody is higher because you already have autoimmunity in your blood. And so we put out a monitoring guidance in June 2024, which has been widely accepted by the diabetes communities. And we are now working on a screening guidance for exactly the question you asked.
That's great. So now we have this continuum of disease. We know that there's different stages. And, why is that important for targeting different therapies?
Yes, because our goal again is disease modification and curing, and ideally reversing the disease if we can. We don't have a reversal yet, but we do have therapies. There's one approved therapy, FDA approved therapy, and now approved in a few other countries like Canada, I believe Israel, one of the Middle East countries, and soon, hopefully, fingers crossed, to be approved in other geographies by their regulatory agencies. This therapy is called Tzield or teplizumab, which is a monoclonal antibody against the main culprit, which is a T cell. Excuse me. And so what we have been able to show is if you have an intervention at the right stage of autoimmunity, then you will be able to curb that and even maybe stop the disease from progressing further. Tzield has been approved right now for stage 2 type 1 diabetes. And just as a reminder for the audience, stage 2 is when you have frank autoimmunity, 2 or more autoantibodies, and dysglycemia during meals. And it has been shown that Tzield is able to delay disease onset, or I would say insulin dependence, by a median of 3 years. And there are some people that have gone for much longer than 3 years. So, and there are about 10 to 12 different therapies being tested in stage 3. This is when your first question, the critical 100 days after diagnosis, is how can you stop the train in its tracks and preserve the remaining beta cell function while we develop a regenerative therapy to regrow the beta cells, which we don't have to.
That makes sense. And, like you said before, we're looking at different immune biomarkers and perhaps using C-peptide as markers for the beta cell function. Changing these endpoints, has this been widely accepted by the regulatory authorities, and has it influenced trial design, looking at lengths of studies, etc.?
Yeah, for the record, Mala, I will state 2 things. One is C-peptide is believed by the clinical research community, such as ourselves and others, to be a validated bona fide surrogate of beta cell function, because C-peptide is clipped from insulin. It's from the in the C end, terminal end of insulin. So right now, it's a very good marker, we believe. Regulatory acceptance of C-peptide as a validated surrogate endpoint is still in the works. And it's in different stages of acceptability, if I can use that word loosely, by different regulatory agencies, FDA, EMA, and others. So it is not yet approved for a therapy approval. However, there has been significant progress with the regulatory agencies through leadership from us and others to be able to provide the evidentiary basis for C-peptide to be an approvable surrogate endpoint, just like hemoglobin A1C became in the 90s. Now, and then you didn't have to do 30-year trials to establish complications, because now you have A1C. We want to be there with C-peptide or any other immune marker that becomes more validated. Why that's important to influence trial design is that now you can design these trials with an intervention for about 6 months, maybe with a 6-month follow-up. And so what happens is trial design becomes more nimble, and you're also using a marker that is direct measure of beta cell function or endogenous insulin production. So it makes scientific sense, it makes clinical sense, and it also makes sense to be able to approve these therapies on that. Plus, there are other clinical benefits, there's often a question on the clinical meaningfulness of C-peptide. It has been shown that C-peptide in the short term also helps in reducing hypoglycemia. And of course, in the long term, as I mentioned before, which is hard to demonstrate in a trial, it gives you protection against complications. Not 100% protection, but protection against complications compared to people that don't have any C. So that's what is influencing trial design now, and maybe we'll get into this in one of the future questions, is about how do we do combination therapies.
No, that'd be great if you don't mind discussing that now. How do we do combination
Yeah,
therapy?
absolutely. I'll go back to the basics where we started. Type 1 diabetes has two problems. You have an active immune system, you have a frank loss of endogenous beta cells. So we believe to be able to fix the disease, cure the disease, you have to address both. It, you know, I don't know if we can address only one and be able to cure the disease. So what we're aiming for is have therapies that addresses the immune system. It's a rebalancing. You can't shut down the immune system because then you're going to have infections. So it's rebalancing the immune system there while we find regenerative therapies that can regrow the endogenous beta cells from germ cells, from pluripotent stem cells that are within the body, and or beta cell protection or survival therapies. They're called protection, they're called survival therapies. There's significant amount of beta cell stress due to the autoimmunity, and maybe some hyperglycemic stress. Now, if you can have therapies that protect against the beta cell stress, and we have good evidence from 2 or 3 drugs right now, not yet approved, but in advanced clinical testing there, we believe ultimately this will be a world like oncology, where you'll have to offer combinatorial therapies that addresses both the immune system and the loss of beta cells here to be able to truly initially stop, but eventually reverse the disease.
Has there been any hesitation in receiving these immune modulators from the general public?
It's early days. I'll tell you then when we do the clinical trials and all those things, there is certainly some amount of education that needs to be done, some amount of diligence that needs to be done. But there definitely has been hesitation. There has been hesitation. There's one, as I said, only one approved immune therapy, TZIL, which I mentioned before here. Significant amount of education needs to be done here. On first, to begin with, on the basics. What is type 1 diabetes, which you started off with? What are the stages of type 1 diabetes, and at what stage do you give TZIL? That is that is moving a boulder to be able to educate the clinical community, healthcare provider, doctors, and allied healthcare professionals here, because they are used to 100 years of managing the metabolic manifestation of type 1 diabetes, which, as I said, is also important. Now, once they know that there is a therapy that can reverse it, so yes, there has been hesitation. There has been some level of clinical inertia in the field, and we and others are working to be able to address those with education and awareness and show the benefits. So there's a lot of studies going on to show the benefits of that beta cell protection or halting autoimmunity or slowing down autoimmunity. We're trying to find clinical effectiveness markers, and we're studying around those here. So yes, there has been. I would not say that it's been a smooth sailing there, just like a closed loop system right now when it gets approved. But we will get there. I'm positive we will get there with more data and the approval of additional therapies, when people will then try understand that this disease, like oncology, like rheumatoid arthritis, like multiple sclerosis, and many other autoimmune diseases, is actually addressable to be able to modify the disease.
We've covered a lot of ground today, from understanding the paradigm shift in treating type 1 diabetes as an autoimmune disease rather than just a metabolic condition, to exploring the critical stages of disease progression and why those first 100 days are so pivotal for preserving beta cell function. What's clear is that we're at an exciting inflection point, with one FDA-approved immunotherapy already available and promising combination approaches on the horizon. We're really moving beyond just managing symptoms to actually modifying the course of this disease. In our next episode, we'll dive deeper into the real-world challenges facing families during those crucial first 100 days, and explore how we can design clinical trials that truly work for children and their families, not just the sponsors. We'll also discuss the vital role of patient advocacy groups in shaping the future of pediatric type 1 diabetes care. Thank you for joining us today, and a special thanks to Dr. Sanjoy Dutta for sharing his insights on this transformative moment here in type 1 diabetes research. Until next time, I'm Dr. Mala Puri, and this is the Fortrea podcast.